So diabetic neuropathy, diagnosis and medical management of diabetic neuropathy. Diabetic neuropathy is a diagnosis of exclusion. So non-diabetic neuropathies also be present in the diabetic patients. So we should not think all the neuropathies in the diabetic patients are due to diabetes. We should rule out other causes also. So there is a 50% of diabetic peoples may be asymptomatic. So we should do regular screening for the asymptomatic patients also to prevent the to diagnose the foot at risk and also to prevent the neuropathic complications, especially injuries and the diabetic foot ulcers. And in turn, we can prevent the foot amputations and also the life of the diabetic patients. So there are multi number of treatment options are available for the symptomatic management to reduce the lancinating pains and the worsening pains, and also we can improve the quality of life. And the last point is we have to recognize the autonomic component of the neuropathy also we should recognize, and we should manage to prevent the complications. Next slide, sir. So we should screen. That is my first part of my talk. That is a diagnosis of diabetic peripheral neuropathy. So we should screen all the patients. So next slide, sir. So when to screen? For ADA recommends that whenever if you come across a type 2 diabetes patient, screen at the time of diagnosis. Then you have to screen every annually. For the type 1 diabetes, you have to screen 5 years after the diagnosis. Then annual screening is required. And you have to assess the neuropathy, especially autonomic neuropathy, for the signs and symptoms, and also especially along with the patients who have microvascular complications. So all the type 2 diabetes patients at the diagnosis itself, we have to screen for diabetic neuropathy. Next slide, sir. So for the diagnosis of neuropathy, we have to go from the systematic approach, from the history and for the clinical examination. For the history, as the previous speaker told, there are various type of symptoms. Maybe a positive symptoms, there may be a negative symptoms, depends upon the types of nerve fiber involvement. So the positive symptoms include burning sensation, tingling sensation, pinprick sensations, lancinating or shooting pains, electric shock-like sensations, pain from non-painful stimuli, that is allodynia, hyperalgesia. These are the positive symptoms. Negative symptoms, which includes the numbness and sensory loss, reduced temperature perceptions, loss of protective sensations, gait instability, and balance impairment. So the most commonest form of the diabetic neuropathy is the glove and stocking distribution. So IID recommends that if the following symptoms are there, you have to do the physical examination based on the history. And many a times 50% I have already told, there are asymptomatic. So we have to do screening test based upon this available simple screening tools. So before after getting the history, you have to do the physical examination of the foot. There may be a foot at risk. So you have to inspect the foot with the skin color, temperature, integrity, structural deformities, especially hammer toes, charcot foots, and callus formations, ulcerations, signs of traumas, especially micro traumas, nail abnormalities, and fungal infections. Then you have to assess the vascular status, especially the dorsalis pedis arteries pulse, and the if we can do AB index also. For the documentation, you have to document every the history and physical examination. Then move on to the clinical examination. Next slide, sir. With the use of simple parameters. So based on the large fiber and small fibers, we can divide into the functions of the foot. The large fiber mainly it is for the pressure and balance function. So if the large myelinated fibers functions are lost, they may be present with numbness, tingling sensation, and balance abnormality. We can examine by the clinical examination by through vibration perception, either may be reduced or absent. Ankle reflexes may be reduced or absent. 10-gram monofilament test for the pressure sense. and for the proprioception also. So this you can assess these simple tests: ankle reflex, vibration perception, 10-gram monofilament test, and proprioception. We can assess the large fibers, whether it is a normal or abnormal. If the small fibers are involved, small myelinated fibers are involved, so they are responsible for the nociception and protective sensation. So if there is protective sensations are lost, so they used to develop the ulcers. Even they may not know that they have the ulcers. The bystanders or sometimes the ulcers may become infected. Infected ulcers may become foul smelling. Then only the patients themselves know that they have some infections. So you have to assess. So they can, if the small myelinated fibers are involved, they may have pain, especially positive sensations like positive symptoms like burning sensation, electric shocks, and stabbing. So you can assess the small myelinated nerve fiber function by the thermal function bed, like hot and cold water, cold sensation discrimination, and also pinprick sensation. So we can assess whether it is reduced or absence. By the way, we can quantify the nerve damage. Next slide, sir. So this is the 10-gram monofilament. It is very simple, easy tool to identify the protective sensation. So if the patient may not feel the 10-gram monofilament pressure, they may have the loss of protection sensation. We have to assess the 10 sites. That is the first, third, and fifth balls of the toes, and the first, third, and fifth metatarsal heads, and the median and lateral midfoot, and the mid part of the heel. We have to assess in the 10 areas. So with the 10-gram monofilament, we have to apply the pressure. We make them to that filament to buckle and ask the patient whether they are feeling the pressure or not. If they are feeling the pressure, we can uh, uh, take it as a positive sensation. If they are unable to detect any site, it indicates loss of protective sensation. So next will be the temperature discrimination. We can use the hot water and cold water testing tubes, or the tuning forks, or thermodes. The instruments, thermode instruments also available, which gives a very accurate temperature, delivers through the probes. So we can ask the patient to identify whether it is a warm or cold. If there is a loss of warmth or cold sensation, it indicates small fiber neuropathy. Next will be to assess the vibration perception. We can use 120 hertz tuning fork. We have to place the bony prominence, especially in the hallux, medial malleolus, or the patella. So if there is a loss of this tuning fork or vibration sense, we have to go from the distal to proximal. So you can use the biotheciometer meter, which is available as an instrument. So it is a graded vibration perception. So we can identify the exact vibration perception threshold by increasing that vibration levels. Then the another small fiber function, that is the pinprick sensation. We can use the neurotip device or small pin heads. We can assess whether the patient is feeling that pinprick sensation or not. Whether we can grading as a sharp or dull or absent the pinprick sensations. So if there is a loss of pinprick sensation in the distal, you have to go from the distal to the proximal. So ADA recommends that these tests not only screen the presence of dysfunction and also which predicts the future risk of complications, neuropathic complications, especially foot at risk and the ulcer risk. The electrophysiological testing or a referral to neurologist is rarely needed. Only in the following situations we need electrophysiological testing and neurological referral, especially when there is an atypical presentation, that is acute or subacute presentation, non-length dependent, asymmetric presentation, there is a predominantly motor involvement, whenever we have a confusion in the diagnosis. So these situations only which requires an electrophysiological testing and neurological referral. So whenever the diabetic patients have neuropathy, we have to rule out other treatable causes of neuropathy, like toxins like alcoholic neuropathy, chemotherapy, neurotoxic medications, vitamin B12 deficiency, hypothyroidism, renal diseases, malignancies, infections like HIV, CIDP, inherited neuropathies, and other vasculitic pathology. So there are other methods to diagnose diabetic peripheral neuropathy. These are theoretical and also for the research purpose. So there are many number of clinical symptoms and signs scoring systems are available. DN4, LANS. There are so many scoring systems are available, and there is a quantitative sensory testing. So there are biothesium are available. Biothesium thermoaesthesiometer, TSA neurosensory analyzer. Many things are available, which is easy to perform, readily available, we can reproducible. So assess the both, it can evaluate the large and small fibers, and which is there is a disadvantage which needs a special equipment, and it is also variable and subjective. And to assess the pseudomotor function, there are neuropads, pseudo scans are available. So which is fast and objective, easy to perform, simple, which is reproducible, but the sensitivity is moderate and uncertain interpretation. So other nerve conduction studies, neurophysiological evaluation for the motor and sensory nerve functions, nerve conduction studies, and which is also objective and widely available. So disadvantages only assess the large fibers and moderate reproducibility, which requires a special equipments. So skin bunch biopsy, which is the intraepidermal nerve fiber density, assess the density. So it is a gold standard to assess the small fiber functions. So, and there are a few disadvantages, like it is a costly, time consuming, risk for infections, especially it is an invasive procedure. So another the examination is the corneal confocal microscopy. So which is Heidelberg Retina Tomograph 3 Rostock corneal module. So which is, there is an advantages are, it's an objective. We can use assess the small fiber functions, and which is reproducible, but the disadvantage is cost, and the requires a specialist, and skills also required to do the investigations. So these are the available investigations, but we need not do all the investigations. We can use the available simple parameters. We can diagnose the diabetic peripheral neuropathy. So moving on to the second part of my talk, that is medical management of diabetic neuropathy. Whenever there is a management, there is a systematic management from the starting from the identifying the pathology to the pathophysiology. So first we have to do the prevention and early intervention of the pathology, that is the disease, that is the glycemia, that is the diabetic. Diabetic control is very important for the management. So whenever we have an adequate glycemic control, even we can prevent the diabetic neuropathy in type 1 diabetes. But in type 2 diabetes, we can delay the progression of diabetic neuropathy. We cannot prevent diabetic neuropathy in type 2 diabetes. And also we have to address the other the metabolic parameters like obesity, hypertension, and dyslipidemia. The next part is the mechanism based treatment. Third will be the painful neuropathy, pharmacological management for the painful neuropathy. The non-pharmacological management will be dealt by the third speaker. So for the glycemic control, key recommendations: early intensive glycemic control is recommended to prevent or delay the onset and progression of diabetic peripheral neuropathy and autonomic neuropathy in type 1 diabetes. Type 2 diabetes, in type 2 diabetes patients, glycemic control is recommended to slow the progression. Only we can slow, we cannot prevent or we cannot delay. We can slow the progression of neuropathy, and we have to give an individual targets based upon the age and other comorbidities, and we have to address the other lifestyle diseases, especially the hypertension, metabolic syndrome, obesity, dyslipidemia, and also we have to do the lifestyle modifications like healthy diet, regular physical activity, avoid smoking and alcohol, which is the important risk factor for the development of neuropathy. And we have to give a patient-centered approach, especially provide an individual education and support, especially based upon their age and comorbidities. So for the treatment of painful neuropathy, the available evidence suggests that all the treatment parameters which I am going to mention that better than the placebo, all the efficacy is comparative within the groups and also compare the other groups. The comparative efficacy is similar to the all the type of drugs which is available for the management of painful neuropathy. The choice of drug selection based upon the side effect, dosing frequency, cost, and regulatory approval status. So we have to choose the agent based upon the above parameters. It should be individualized. So these are the first line drugs for the management of painful diabetic neuropathy. So FDA approves only the duloxetine, pregabalin, and the capsaicin patch. Only 3 drugs are approved by FDA. The other drugs classifications are SNRI, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, and the gabapentinide anti-seizure medication. These are the first line drugs. You have to choose these drugs based upon the comorbidity. Whenever the patients have the restless syndrome, essential tremors, insomnia, you can choose to prefer the gabapentinide and medications. Whenever the patient has depression and anxiety, you choose SNRIs. Whenever the patients have the TCAs are second line. Whenever the patient has cardiac disease, prolonged QTC, and orthostatic hypotension, and urinary retention, angle closure glaucoma, you should avoid TCAs. You should prefer other drugs. And this gabapentinide, especially in COPD and peripheral edema, you should avoid gabapentinide medications. So among the SNRIs, duloxetine and venlafaxine are available. TCAs are amitriptyline, nortriptyline, desperamine, gabapentinide, pregabalin, gabapentin. So other drugs like sodium channel inhibitors, especially carbamazepine, oxcarbazepine, lamotrigine, locosamide, and valproic acid, which reduces the neuronal excitability by blocking the voltage-gated sodium channels. They are used especially when the SNRIs are ineffective and are contraindicated. So the opioids and atypical opioids like tapentadol and tramadol, which are centrally acting analgesics, with both are opioid agonists and norepinephrine reuptake inhibition properties. It is considered as in refractory cases, but there are more risk rather than the benefit, which are especially risks of dependence and adverse events. So which provides pain relief, but there is high risk of addiction and safety concerns limit their use. But ADA does not recommend as a treatment for the painful neuropathy, tramadol and tipentadol, especially opioid, atypical opioids. And the other agents are topical agents like capsaicin 8% patch and lidocaine patch, which are provides localized pain relief by desensitizing the nociceptive fibers. This capsaicin 8% patch are approved by FDA. So other group of drugs, that is the mechanism-based treatments. First group will be the neuroprotective agents, that is the methylcobalamin, vitamin B12, active form of vitamin B12, which improves the regeneration, nerve regeneration and myelin sheath formation, which promote the synthesis of nucleic acid and proteins within the nerve cells, which facilitates the axonal regeneration and improving the nerve cell conduction velocities. And this neuroprotective agents, which is also helpful for the management of the painful neuropathy and also the reduce the symptoms of neuropathy. The next group is antioxidants, that is alpha lipoic acid, which prevent the oxidative stress by antioxidant property. The oxidative stress is the major predominant pathology in diabetic neuropathy, so which helps the reduce the oxidative stress and also which inhibits the lipid peroxidation and improves the endoneuronal blood flow. So this enhance the nerve glucose uptake and energy metabolism, and significantly improves the neuropathic symptoms and nerve conduction velocities. Prevents the accumulation of sorbitol and fructose within the nerve cells, by which it reduces the osmotic stress and neuronal damage. And it improves the metabolic imbalance associated with the diabetic neuropathy, and which alleviates the symptomatic improvement and enhances the velocities, conduction velocities. Another groups are microcirculation enhancers, that is the prostaglandin E1 and its analogs, which acts as vasodilators, which improves the microcirculation and reduces the platelet aggregation. So it improves the peripheral neuropathy, especially by increasing the nerve conduction velocities, and also which is the effect is better when combined with neuroprotective agents like methylcobalamin. So the pentaxyphylline, which improves its microcirculation by decreasing the blood viscosity and enhancing the erythrocyte flexibility, which improves the nerve conduction velocity and reduce the neuropathic symptoms. This chylidinogenase, and it's another microcirculation enhancer, which increases the capillary blood metabolic enhancer. So the another metabolic enhancers are acetyl N-carnitine, which facilitate the fatty acid transport into mitochondria, enhancing the cellular energy production. So which has the neuroprotective properties, which relieves the neuropathic pain, improves the sensory function, and also which increases the nerve fiber regeneration and enhance the nerve conduction. So we can choose all among the groups. From the glycemic control, we can give the pain medications along with the mechanism-based therapies. So the combination therapy will give more benefit and more the symptomatic relief, and also improve the nerve regeneration and nerve function rather than the single treatment. Thank you very much for the patience listening.
We can move on to the next talk, non-medical therapy and neurotherapy for diabetic neuropathy.
First of all, I thank all the faculties and faculties of the Diabetes Knowledge Academy for giving me this opportunity to present on this topic. And my topic for discussion today is non-medical therapy and neurotherapies for diabetic neuropathy. In this discussion, we are going to discuss about the lifestyle modification, physical therapy, and novel methods. Lifestyle modification, Dr. Ramesh has already described in detail about the lifestyle modification. I will slightly touch upon the lifestyle modifications. First one is the dietary changes. A balanced glycemic diet is very much essential for arresting the progression of diabetic neuropathy. And next is the structured exercise pattern. The structured exercise means there are certain exercises under trial which has given a positive benefit for diabetic neuropathy. First one is Tai Chi exercises. It is a Chinese martial exercise which was under trial in few trials, which has given a positive benefit for diabetic neuropathy. And next is yoga. 30 to 40 minutes of yoga for 40 consecutive days has shown benefit in some trials for diabetic neuropathy. And next is orthotic footwear is very much essential for preventing skin ulcers and arresting the progression of diabetic neuropathy. And the annual foot examination is very much essential in all cases of diabetes and diabetes neuropathy. And smoking cessation, obesity management, and strict blood pressure control are very much essential. And pathogenetic treatments has also been described in detail by Dr. Suresh, so I'm not going to talk much about that. And my main topic is non-medical management of diabetic neuropathy. Among this is there are 7 available methods of physical therapy available. First is a transcutaneous electrical nerve stimulation, then electrical spinal cord stimulation. Next is percutaneous electrical nerve stimulation, which is a slight modification of transcutaneous electrical nerve stimulation. And the fourth one is magnetic field therapy. Fifth one is low intensity laser therapy, then monochromatic near infrared treatment, and the last one is electroacupuncture. Coming to transcutaneous electrical nerve stimulation, which is also known as TENS therapy. This is a TENS device. It uses a low voltage electrical current to block pain and change perception of the pain. TENS unit is a battery powered device with electrodes that deliver electrical impulses through the surface of the skin. The electrodes are placed at or near the trigger points of the affected nerves. The electrical potential they cause the stimulation of peripheral A beta sensory fibers, and which in turn suppress the A delta fiber nociceptive pain perception. Hence, by this mechanism, it causes improvement in pain, numbness, and allodynia. Allodynia is painful sensation resulting from non-painful stimuli. The cyclical doses of the electrical stimulation through the contact stocking electrode, it is very effective in alleviating the neuropathic pain. American Academy of Neurology has given a level B recommendation for TENS therapy in diabetic neuropathy. It is effective in reducing pain in even refractory cases. The advantages of TENS are it is non-invasive, it can be used alone or in addition to other pain relievers. It also reduces the dosage of medications needed in some people. TENS unit is very small and portable, it is very handy, it can be taken anywhere, and it effectively relieves pain for many people. There are minor disadvantages in TENS therapy. The adhesives used in electrodes can cause minor allergic reactions in some people, and it can cause the electrical sensations can cause uncomfortable sensations like tingling sensation or burning sensation. And rarely the electrodes can cause minor burns at the degree of contact, at the area of contact. The next mode of physical management is electrical spinal cord stimulation. It was pioneered in late 1960s by Dr. Norman Daly. He was a neurosurgeon who implanted first dorsal column stimulator in a patient suffering from terminal metastatic cancer. Spinal cord stimulation involves the implantation of electrodes that generate pulses. The pulses interfere with transmitting pain signals to the brain. So once the transmitting pain signals are interfered, the perception of pain is also reduced or altered. The mechanism of action of electrical spinal cord stimulation is it produces an electrical field on the dorsal horn of the spinal cord, thereby interfering with the pain perception pathway. Another proposed mechanism is it may also activate the descending serotonergic pathways, thereby inhibiting the spinal nociceptive processing. This is the electrical spinal cord stimulation device. What we do here is we implant a small electrode wires into the dorsal epidural spaces. The electrical impulses are delivered to the dorsal spinal cord through these leads from the IPG. This is the implanted pulse generator, IPG. The electrical leads of the spinal cord stimulator will span around 2 to 3 vertebral bodies levels in the epidural space, and they deliver the stimulation to the predetermined area depending upon the specific condition already being treated. The settings of the device can also be adjusted after implantation to meet the patient's targeted pain areas or functional goals using a wireless programmer that communicates with the IPG. This is another picture of electrical spinal cord stimulation device. It is used in the management of chronic neuropathic or intractable pain. In one study, 10 kilohertz spinal cord stimulation offered a comprehensive treatment that improved pain levels, improved sleep, quality of life, and improved general neurological function. The one disadvantage is it is slightly expensive and it is invasive compared to the TENS therapy. The next one is percutaneous electrical nerve stimulation. The only difference compared to the TENS therapy or transcutaneous electrical nerve stimulation is it uses the needles to deliver the electrical currents instead of the electrodes. So it combines the aspect of traditional acupuncture and TENS therapy. So it involves inserting thin needles into the skin near the affected nerves, which are then connected to the low voltage electrical generator. One difference from the TENS therapy is it causes deeper penetration of electrical impulses into the tissue because of the thin needle is inserted into the affected tissues. The mechanism by which pain relieving is obtained is it creates an electrical field that hyperpolarizes C fibers, so thereby preventing the action potential propagation along the pain pathway of small diameter pain fibers at the spinal cord level. So hence pain perception or pain transmission is inhibited. It also stimulates the release of endorphins and other neurotransmitters. Its advantage is it improves physical activity and improves the sense of well-being and quality of life. It reduces the requirement of oral non-opioid analgesic medications. The next mode of therapy is magnetic field therapy. This is the picture of the magnetic field therapy. It is a complementary treatment that uses magnets to promote healing and alleviate pain. There are two types of magnetic field therapy. One is static magnetic field therapy. This is the pulse magnetic field, electromagnetic field therapy. The other one is a static magnetic field therapy. Among the studies under trial, static magnetic field therapy has shown some benefit in reducing the neuropathic pain compared to the pulsed low frequency electromagnetic fields. How do we use static magnetic field therapy is we wear a constant multipolar sole in the shoe where the patient has diabetic neuropathic pain. So the sole should be in contact with the painful area, and by contact with the magnetic field, it causes a reduction in neuropathic pain. The studies show pulse low frequency electromagnetic fields does show no benefit in diabetic neuropathic management. So the other uses of the magnetic field therapy are it has uses in arthritis, other chronic pain, wound healing, insomnia, and headaches. The patients with pacemaker cannot undergo this magnetic field therapy. And the other thing is low intensity laser therapy. It involves the application of low power lasers or light emitting diodes to the surface of the skin. It acts by mechanism of photobiomodulation. What is photobiomodulation is from the lights of light emitting diodes or low power lasers, the light photons are absorbed by the chromophores in the cells, the mainly cytochrome C oxidase in the mitochondria. So the resultant action is there will be increased production of ATP for cellular energy. It enhances cell proliferation and tissue repair, and also there is a modulation of inflammatory mediators, and improved circulation and oxygenation of tissues is also obtained. So this is the low intensity laser therapy device. In a clinical trial, bi-weekly therapy of low intensity laser therapy for about 4 weeks in 50 diabetic patients showed reduction in weekly mean pain scores. The minor adverse effects are there will be warmth and redness at the laser applied areas. And next thing is the next physical therapy is monochromatic near infrared treatment. It is more or less similar to the low intensity laser therapy. It is an FDA approved treatment for diabetic retinopathy. It uses an array of 60 gallium aluminum arsenate light emitting diodes placed in direct contact with the target skin. It also acts by mechanism of photobiomodulation. And another proposed mechanism of action of monochromatic near infrared treatment is the release of nitric oxide. So thereby it increases the food sensitivity and reduces the neuropathic pain. The last mode of physical therapy is electroacupuncture. In the electroacupuncture, we are inserting thin sterile needles into the specific points of the body. Once inserted, these gentle electric currents are applied through the needle. How they act is they stimulate the sensory nerves, which send signals to the brain and spinal cord. Once the brain and spinal cord receive signals, it triggers the release of neurotransmitters like endorphins and serotonin, which help in reducing the pain and promote well-being. The electrical impulses also improve blood flow, delivering oxygen and nutrients to the tissues, accelerate healing and reducing inflammation. It is relatively inexpensive, painless, and comfortable to use. The release of neurotransmitters depends on the frequency of stimulation. If 2 Hz stimulation is used, the neurotransmitters released are enkephalin and endorphin, whereas 100 Hz stimulation releases dynorphin neurotransmitter. So my next topic is novel therapy in treatment of diabetic neuropathy. There are 3 novel therapies currently under trial. First is the supplementary therapy with exogenous cytokines. Next is cell transplantation therapy, and the third one is exosome therapy. Supplemental therapy with exogenous cytokines is we are delivering the cytokines via gene transfer of these factors or by administration of the recombinant proteins. It usually elicits some therapeutic effects. But disadvantages, most studies are limited to animal experiments currently. In animal experiments, it showed improvement in nerve blood flow or nerve function through angiogenesis. The 4 exogenous cytokines currently showing positive benefit are hepatocyte growth factor, HGF, then basic fibroblast growth factor, BFGF, then nerve growth factor, then placental growth factor 2. So hepatocyte growth factor delivered by a non-viral liposome mediated gene transfer, it causes improvement in nerve conduction velocity, whereas basic fibroblast growth factor delivered by intramuscular injection of the recombinant basic fibroblast growth factor protein. It causes improvement in the motor nerve conduction velocity of the sciatic nerve, and it improves the sciatic nerve blood flow also. Then nerve growth factor delivered by recombinant protein, it causes improvement in thermal allodynia in the streptozotocin induced diabetic rats. In the last one, cytokine placental growth factor 2, delivered by intramuscular gene transfer of the plasmid DNA by electroporation method. It improves the hypoalgesia and restores sensory nerve function in diabetic mice. Disadvantages of supplemental therapy with exogenous cytokines is there is a low expression efficiency of the introduced gene vector. Hence, the therapeutic effect obtained is very minimal, and the gene expression is also very transient one. So we cannot achieve a long-lasting effect. The next novel therapy under trial is cell implant transplantation therapy. 3 cells are currently under trial. First is a mononuclear cell, next is the mesenchymal cells, and the other one is the endothelial progenitor cells. Mononuclear cells are derived from the bone marrow. It causes improvement of the mechanical hyperalgesia and cold allodynia. It also causes improvement of the sciatic motor nerve conduction velocity and sensory nerve conduction velocity. The mesenchymal stem cells derived from the bone marrow. It causes improvement of the mechanical hyperalgesia, and it also restores the function of nerve conduction velocity and sciatic nerve blood flow in animal studies. And the last one, endothelial progenitor cells, it's derived from the umbilical cord blood. It causes improvement in the sciatic motor nerve conduction velocity and sciatic nerve blood flow. And the advantage of cellular cell transplantation therapy is it has an advantage of continuous expression of the factors necessary for tissue regeneration. In comparing to the exogenous cytokine supplementation, exogenous cytokine supplementation has low expression efficiency, whereas cell transplantation therapy has a continuous expression of factors. That is the advantage. But there are few concerns about the safety of the cells that are being used for transplantation. The quality and safety of the cells are being under question. And the long-term expression of the biologically active substance like these cells can cause untoward side effects like tumorigenesis. The third method under trial is exosome therapy. What is an exosome? Exosomes are vesicles secreted by the cells usually of size 30 to 120 nanometer. It has a lipid bilayer structure, and it is a signal mediator for cell-to-cell communication. So there are 2 exosome therapy under trial currently. First one is the Schwann cell derived exosomes derived from Schwann cells. It causes improvement in sciatic nerve conduction velocity and increases thermal and mechanical sensitivity in diabetic mice. The second exosome therapy under trial is mesenchymal stromal cell derived exosomes. It is derived from bone marrow, and it causes improvement of the thermal and mechanical sensitivity similar to Schwann cell derived exosomes. It also causes improvement in sciatic motor nerve conduction velocity and sensory nerve conduction velocities. It has an advantage of both cell transplantation therapy and exogenous cytokine transplantation therapy. But one disadvantage is we need more efforts for establishing cell lines to produce enough exosomes and standardizing the quality of the exosomes produced. That is the current challenge available now. Thank you, sir. Thank you.
Diabetic neuropathy refers to the development of peripheral nerve dysfunction in patients with diabetes when other causes are excluded. So it is a diagnosis of exclusion, and it is one of the most frequent and chronic complications in long-standing diabetic patients. In the presence of abnormal metabolic factors, and the normal structure and functions of the peripheral nerves are disrupted. So going into the epidemiology of diabetic peripheral neuropathies are by itself is the most common neurological problem encountered worldwide in the medical practice. So the prevalence of peripheral neuropathies increases with the age. From 2 to 3% in individuals who are 50 to 60 years, and 13% in individuals who are between 70 to 80 years, and it gradually increases to 30% in individuals who are more than 80 years. So from the above prevalence, more than 50% of peripheral neuropathies are diabetic peripheral neuropathies. As the number of diabetic patients increase worldwide, diabetic peripheral neuropathy has become a global health challenge. It is also considered as one of the costly complications of long-term and long-standing diabetes. The aggregated national annual cost for treating painful diabetic neuropathy and its complications like diabetic foot ulcers and limb amputation is estimated to be around 4 billion to 13 billion dollar a year. So going into the clinical phenotypical classifications of diabetic peripheral neuropathy, we classify it into three types. Usually the subclinical type, the painful type, and the painless type. Usually in the subclinical type, the patient is usually asymptomatic, whereas in painful type, there is hyperexcitability, ectopic neuronal activity, and in painless type, the patient is having hyposthesia and anesthesia. So the mainly the small fibers are involved in the painful type of diabetic peripheral neuropathy, whereas large fibers are damaged in painless diabetic peripheral neuropathy, which results in loss of proprioception and touch sensation. These patients with painful diabetic peripheral neuropathy experience burning, tingling, and sharp electrical pain-like sensation with allodynia and hyperalgesia. Usually, the nerve conduction studies show abnormal nerve conduction, and there is a reduced sensory threshold to pain. In case of painless peripheral diabetic neuropathy, there is numbness and tingling with loss of sensation without pain. So there is decreased or absent sensation and slow nerve conduction velocities. In mixer type, both the small and the large fibers are involved. So going into the pathophysiology, diabetic peripheral neuropathy is characterized by a stocking and glove distribution of distal symmetric polyneuropathies. It is caused by loss of myelin in the myelinated fibers. This results in injury to the unmyelinated nerves and axonal atrophy, which ultimately results in abnormal nerve conduction velocities and abnormal sensory functions. The disease features results from a specific anatomy of the motor and sensory neurons and the glial cells in the peripheral nervous system, which we will be discussing in the next slide. So here there is the major pathophysiological mechanism where there is a significant myelin loss, which results in axonal damage and neuronal apoptosis, which results in abnormal nerve conduction velocities and abnormal sensory functions. So in this image, we see a myelinated neuron which is protected by the Schwann cells. So the peripheral nerve is composed of myelinated axons with the cytoplasmic process and the Schwann cells. The Schwann cells are nothing but a type of glial cells. These glial cells are important for nerve conduction velocity because they have the characteristic of insulating and providing conduction for rapid saltatory conduction of action potential over a long distance. So the myelinated fibers have these glial cells, whereas the small axon forms are have non-myelinating remark bundles. This myelin is rich in receptors and adhesion molecules. This type of receptors and adhesion molecules help in maintenance of periaxonal space and translocation growth factor signals from the axons. So under the influence of these metabolic factors like hyperglycemia, hyperlipidemia, and through various signaling pathways, the regulatory functions of the Schwann cells are damaged, resulting in a mitochondrial dysfunction, which occurs through a series of pathways. Without the protection of the support of these glial cells, the sensory neurons become more vulnerable to the injury than the motor neurons, especially the neurons from the dorsal root ganglion. So this is a small summary about the pathophysiology. A diabetic patient who's undergoing a series of oxidative stress and metabolic abnormalities with microangiopathies, there is a destruction of the normal structure and function of the nerve cells. This results in neuronal demyelination and neuronal damage, resulting in peripheral neuropathy. So the major factors which provoke the peripheral neuropathy through major pathways are hyperglycemia, hyperlipidemia, insulin resistance, and microvascular disorders. Among these, hyperglycemia and hyperlipidemia progress through peripheral neuropathy through the protein kinase pathway, the polyol pathway, the advanced glycation end pathway, and hexosamine pathway, along with PAPR pathway. So I will move on to the types of diabetic peripheral neuropathies. Four major types are diabetic distal symmetric sensory and sensory motor polyneuropathy, diabetic autonomic neuropathy, diabetic radiculoplexopathy, and diabetic mononeuropathies or multiple mononeuropathies. So going into the most common form, which is the diabetic symmetric sensory and sensory motor polyneuropathy, the sensory loss usually begins in the toes, which gradually progresses into the legs and into the fingers and arms later. In more severe cases, the sensory losses progresses to the trunk, which is more in the midline, then midline and anterior part, and then progresses later to the lateral region. The patient experiences severe tingling and burning and deep aching pain. Uh, the investigation, as we investigate the patient, there is reduced amplitude with mild to moderate slowing of conduction velocity in nerve conduction studies. The nerve biopsy shows axonal degeneration, endothelial hyperplasia, and perivascular inflammation. So the treatment majorly is on maintaining a tight glycemic control, tricyclic antidepressants, antiepileptics, sodium channel blockers, and analgesics. Next is the diabetic autonomic neuropathy, which usually occurs in combination with DSPN. So here the patient experiences abnormal sweating, dysfunctional thermoregulation, dry eyes, dry mouth, pupillary abnormalities, cardiac arrhythmias, and GA abnormalities like diabetic gastroparesis and postprandial bloating. So patient also experiences genitourinary dysfunctions. So investigation is majorly on sympathetic skin response test and quantitative pseudomotor axon reflex testing. So nerve conduction study shows same as that of DSPN, which is reduced amplitude with mild to moderate slowing of conduction velocity. Next, we will go on to diabetic radiculoplexus neuropathy. It is also called as Burns-Garland syndrome. Here, the patient experiences a lower backache with hip pain and thigh pain, which is mostly localized to one leg. The patient has atrophy and weakness of the proximal and the distal muscles in the affected leg. As the weakness progresses from weeks to months, the pain also gradually increases. So here it is most common. The most common form is the typical form, which is the lumbosacral radiculopexopathy, plexus neuropathy, whereas the atypical forms like thoracic radiculopathy and cervical polyradiculoneuropathy can also occur, which is very rare. Investigations, usually invasive investigations like lumbar puncture is not usually preferred, but CSF analysis show high proteins and normal cell count. ESR counts usually rises, and there is evidence of active denervation in the affected proximal and the distal muscles in electrodiagnosis. Nerve biopsy shows axonal degeneration along with perivascular inflammation. The next is the diabetic mononeuropathies. Patient usually experiences medial nerve mononeuropathies at the level of the wrist joint and ulnar neuropathy at the level of elbow. Cranial neuropathy most commonly occurs and involves the seventh cranial nerve. Third, sixth, and fourth cranial nerve are also involved, whereas the least common is the fourth cranial nerve. There is always pupillary sparing in case of diabetic third nerve palsies. So my take-home points is to understand polyneuropathy and its association with diabetes, the need for effective and adequate glycemic control among these diabetic patients, early diagnosis and treating the complications, understanding the global and economical burden of diabetic polyneuropathy, and the need for addressing patients with diabetes without any delay. Thank you.
So very good presentation, actually it was. And I invite Dr. Raja to deliver the vote of thanks and also discuss about the questions that has
Before that,
appeared
we
in
have
the
three
chat
questions in
box.
the chat box, sir. Raja, sir, you can ask those questions, sir. Three questions in the
Yes,
chat
sir.
box, sir.
Okay, sir. Sir, can you read? I will.
Yes, sir, I
I
will read,
have.
sir. The first
I'll.
question, Any speaker can take this question. With all these modalities of treatment for diabetic peripheral neuropathy, is it possible to completely reverse it back to a normal?
It's already answered, sir. We cannot
Yes, sir.
reverse, completely reverse. We can delay the progression of the disease, neuropathy. We cannot completely reversible.
Okay, sir. We have one more question, sir. Generally, the positive symptoms respond very well to all medications. But what about negative sensory symptoms like numbness? How we should approach for the negative symptoms and the second, first you can answer this question, sir. We have a second part also, sir, this question.
So all the drugs which are we mentioned and discussed are mainly for the positive symptoms, especially for the painful diabetic neuropathy, and other drugs which are mechanism-based drugs which are dealing with the pathophysiology of the diabetic neuropathy. Whenever the positive symptoms are there, you can give these drugs and we can get the symptomatic relief. For the negative symptoms, which shows that the nerves are already died, so there is no nerve function. So we can prevent the preventive measures by doing the like wearing the adequate footwears and doing other metabolic parameter control. So we can do that preventive measures only we can do to ulcer or the neuropathy complications. We can prevent the complications, like protect the foot with the preventive measures.
Okay, so the second part of the question is, what is the treatment option available for a significant motor weakness and disability in advanced motor sensory axonal neuropathy? What are the options available currently? And we don't have any specific treatment, sir. What about your view, sir?
He's asking advanced motor sensoral neuropathy. Is there any
Weakness
advanced
and
treatment
disability.
like maybe third speaker, sir? Advanced treatment ஏதாவது இருக்கா சார் நீங்க பார்த்ததுல?
Dr. Karthik, what
Advanced
about
treatment,
spinal cord stimulation?
only we can do spinal cord stimulation and all therapies. Once they have come to effect, we can try that, sir. Currently, I don't know whether any advanced treatment is effective or not for the advanced motor sensory axonal neuropathy.
And Dr. Venkatesh has asked us one more question. When to suspect a non-diabetic neuropathy in a diabetic? We all tell that it is a diagnosis of exclusion. Then when to suspect a non-diabetic neuropathy in a diabetic patient?
Sir, which is also answered in that chat
Mentioned,
box.
sir.
Whenever you have a asymmetric involvement, rapid progression, predominantly motor weakness rather than the sensory, proximal involvement rather than the distal, upper limb involvement, then there is a discordance between the clinical presentation and the pain management. Then there is a rapid progression with the adequate control of blood sugars. Then the cranial nerve involvement, family history of any inherited neuropathies, then other systemic diseases like hepatic renal diseases, and other toxins or drugs on drugs, then you have to think other causes of neuropathy.
Including any patients on renal, CKD patient or hepatic failure patient, and even with patient with hypothyroidism, they may develop symptoms of neuropathy, sir. Yes,
Yes.
sir. Excellent, sir. Any other questions, sir? Any other doubts, sir?
Any other questions?
And one more question, sir. Can pharmacotherapy treatment being given prophylactic for diabetic peripheral neuropathy once you see a patient on uncontrolled diabetes? Whether it can be given as a prophylactic, sir? What is a view to give a prophylactic treatment for diabetic peripheral neuropathy in patient with uncontrolled diabetes?
Sir, if there is a pain, we can give pain pharmacotherapy. If there is no pain, then we can control the glycemia and other metabolic parameters, and also we can give the pathophysiological mechanism-based therapies like vitamin B12. That is the pathophysiological mechanism which helps some amount of pain relief and some amount of progression of arrest the progression of nerve cell damage, like alpha lipoic acid and methylcobalamin, like that. So primary thing is glycemic control and other metabolic parameters control. That is the main pathology that you have to arrest by the controlling of the drugs and other lifestyle modifications.
Yes, sir. Uncontrolled blood sugar itself causes a tangential increase in neuropathic symptoms, sir. Once you are going to control the blood sugar and having a good glycemic
They
control,
will have a
definitely symptoms will be improved, sir.
Improved, yes,
Positive
sir.
symptoms will be improved, sir. Yes, sir. Yes, sir. Thank you, sir.
So one more question. Any role of vitamin D, magnesium, zinc in prevention or treatment of DPN?
There is no approved therapy, sir. As per the guidelines, there is no vitamin D, magnesium, and all in the pathophysiology of development of neuropathy, diabetic neuropathy. Diabetic neuropathy is concerned.
What about the large dose of methylcobalamin are often given as a part of prescription, especially in a combination with pregabalin? Is this rational? Are there any adverse effects?
Hello, which is
The
the earliest complication in uncontrolled diabetes, sir? Is it DPN or retinopathy?
Pardon, sir, come again, sir.
In uncontrolled diabetes, long-standing diabetes, the earlier complication may be DPN or retinopathy, sir.
Retinopathy symptoms occurs even with a HbA1c of 5.8 and 5.9, sir. Retinopathy occurs earlier, sir, but mostly it occurs corresponding with the neuropathy symptoms, sir.
Okay, sir. Let we finish, sir.
Yes, sir, you can wind up, sir. And vote
Yes,
of
sir.
thanks
Yes,
will
sir.
be given by Dr. Raja, sir. He's
Yes, sir.
an excellent clinician. He has chosen this topic. He has chosen this speaker. I hand over the meeting further to Dr. Raja, sir.
Sir. Good evening, sir. Good evening, everybody. It's a wonderful topic. It's a very commonly encountered everybody in our clinical practice every day. It's the patient also very happy whenever we are treating this neuropathy, diabetic neuropathy. The patient will be very happy, even though uh, even not controlled with the blood sugar, the patient will happy if you treat the diabetic neuropathy. So that's what we are. Everybody's we have in control. Some of the time we are not able to control. That's very difficult challenge. It's a diabetic neuropathy treatment. So that's what we selected this topic. It's everybody. All speaker are well done. So first of all, I would like to thank our Dr. Ranjit sir. Is making this arrangement and giving this all speakers and calling all the speakers and everybody. So they are making the arrangements also. And also, I would like to thank Dr. Vinod sir. He's making that this program is wonderful event. And also the all speakers like Dr. Bharat sir, he's wonderful. He explained everything about physiology and epidemiology and pathophysiology and things types of diabetic neuropathy. And Ramesh, he is my he's a student in Raipeta when I was working there. So he's wonderfully he's explained everything there, the medical management. Done well, Ramesh and Karthik sir. He did all. He explained very well about non-pharmacological therapy. So we know that not only we know that a lot of treatment was available nowadays without the medical management. We know that a lot of treatment was available is available now. Things and also I once again. Thank to all the participant and make this event is wonderful. Thank you, sir. Thank you, Ranjit sir, and thank you, speakers, and thank you, Vinod sir.